Okay, hello everyone. Very welcome to this live webinar from the EFLM. Thank you, Daniel, for your presentation. And let me all introduce the speaker of today's webinar, Professor Giuseppe Lippi, a very well-known professional from laboratory medicine. Professor Lippi was born in Padova, Italy, and his degree in medicine, specialization in clinical biochemistry and laboratory medicine. Currently, he's a full professor of clinical biochemistry and molecular biology at the University of Verona, the director of the clinical chemistry and hematology laboratories of the University Hospital of Verona, has participated in more than 1,400 articles in peer-reviewed journals with an outstanding impact factor and age index, participant in more than 500 national and international congresses and more than 250 lectures, awards in 2014 and 15 at the EACC, research grants from the European community, different research projects. Sorry, we lose the, yeah. Editor-in-chief or associate editors of different significant journals of our field. At the EFLM, he is the national representative of the Italian Society. He's also a member of the working group of preanalytical variability, and in this year appointed as secretary of the EFLM. And his fields of research are preanalytical variability, analytical and clinical validation of biomarkers, acute coronary syndromes, metabolism of lipoproteins, frailty, and diagnosis and management of disorders of hemostasis. And this last topic is going to be the one that he's going to cover today with this live webinar. For the next 40-45 minutes. After it, we will have several minutes for question and answers. I hope that you will enjoy this outstanding presentation. Please, Professor Lippi.
Thank you, Antonio. Dear Antonio, Daniel, dear friends and colleagues. It is a real pleasure to hold this webinar for the European Federation of Clinical Chemistry and Laboratory Medicine on a topic that has fascinated me for over 25 years. Before going into deep on the issue of diagnostic testing of hemostasis disturbances, I will little abuse of your patience for introducing some key concepts about physiological and pathological hemostasis, which are actually essential to better understand the complexity of laboratory hemostasis. Let me start with the simple concept that physiological hemostasis is a complex and multifaceted system in which both pro- and anticoagulant forces actively cooperate to either preserve blood fluidity under normal condition or to trigger clot formation to prevent excessive bleeding when the integrity of the blood vessel is jeopardized. A fine balance between these opposite forces is always essential for the survival of all animal species with blood circulating in their body. In practical terms, hemostasis can hence be conventionally defined as a dedicated balance between opposite forces which on one end maintain blood fluidity in normal blood vessels and on the other end prevent excess bleeding when the blood vessels are injured. In a mechanistic perspective, physiological hemostasis can be figured out as an interplay between many variables and effectors which especially include blood vessels, platelets, and coagulation factors. The complex activity of this multifaceted system is then finally regulated by a number of inhibitory mechanisms whose function is principally aimed to limit the extent of clotting in both terms of site and amount. Therefore, an excessive prevalence of anticoagulant forces developing after blood vessel injury would lead to various degrees of hemorrhage that can reach even life-threatening severity, whereas an excessive activity of procoagulant forces under physiological condition, for example when there is no blood vessel damage, would in turn lead to extensive or excessive coagulation and, as a consequence, would lead to thrombosis. Essentially, the modern model of hemostasis can be divided into two main phases. The former, defined as primary hemostasis, primarily involves the platelet-vessel interplay, while the latter, defined as secondary hemostasis, almost exclusively involves coagulation factors and in part platelets, at the surface of which the so-called coagulation cascade develops. Although we cannot really draw a straight line to separate the pathophysiological mechanisms sustaining hemorrhages due to disorders of the primary or secondary hemostasis, the related symptoms can then be clustered into quite discrete groups. Specifically, bleeding due to disorders of primary hemostasis tend to occur with the so-called superficial hemorrhages, and so include bruising, petechiae up to purpura, ecchymosis, as well as bleeding from gums after invasive procedures and metromenorrhagia. On the other hand, bleeding due to disorders of secondary hemostasis tends to be associated with more profound hemorrhages, so including the formation of hematomas and bleeding into joints, muscles, gastrointestinal or genitourinary tract, in other soft tissues or in the central nervous system. As previously emphasized, this separation should not be taken for granted, since there are many possible overlaps, as well as bleeding disorder in which all the signs and symptoms may be contextually present, such in this case the typical case of von Willebrand disease. Although the platelet-vessel interplay is an essential part of the hemostasis process, only platelet disorder have been convincingly associated with bleeding, while the impact of possible vessel disorder beside their injury is less recognized. Briefly, the blood vessels participate to the hemostasis process with three mechanisms, which include release of prothrombotic or procoagulant substances, exposition of prothrombotic and proaggregant surfaces like collagen, and at the end, vasoconstriction. This last aspect is especially important in arterial blood vessels, which are characterized by a much larger content in muscular fibers, the role of which is to generate vasoconstriction, thus reducing the caliber of the vessel and at the same time the amount of blood lost. This is a quite easy and straightforward concept. The lower the caliber of the vessel, the lower the volume of the blood inside the vessel, and reasonably, the lower the amount of the blood loss. Now, how primary and secondary hemostasis interplay in physiological and pathological hemostasis is clearly shown in this slide. Basically, a primary endothelial injury is rapidly followed by accumulation of a large number of platelets to the site of injury. Platelets are then subjected to a sequential process of activation, adhesion to the subendothelial matrix exposed after vessel wall injury, and finally aggregation. The two last phenomena are mainly mediated by interaction of fibrinogen and von Willebrand factor with specific glycoproteins present at the platelet surface. However, as more deeply discussed in other parts of this presentation, this original hemostatic plug is fairly unstable and is vulnerable to rapid dissolution within the bloodstream, especially in arterial circulation. It is exactly at this point that secondary hemostasis, which is also known as blood coagulation, comes into play. To put it simply, I will make a banal but probably straightforward example. I guess that most of you already know the funny story of the three pigs who were persecuted by a hungry wolf. To protect himself from the wolf, the first little pig built a house of straw, but the wolf blew it down and ate him. The second little pig, having learned the lesson from his brother, built a house of fir sticks, which the wolf also blew down and ate him. The third little pig, which was probably much more clever than his former brothers, built a house of bricks, which the wolf failed to blow down. What is the take-home message of this joke? It is quite simple. The initial platelet plug is not enough resistant to counteract dissolution within the blood flow, so that something else is needed to be reinforced and to withstand the blood flow. And this essential element is actually fibrin. The process leading to the generation of fibrin is probably one of the most biologically intricate mechanisms in the entire human biology. All coagulation factors belong to the class of proteolytic enzymes and are synthesized as inactive precursors, they are called zymogens, to prevent unwanted protein activation or degradation, and to enable spatial and temporal regulation of the coagulation cascade. Upon sorting or appropriate compartmentalization, zymogen conversion to the active enzyme typically involves a limited proteolysis of the protein, and the further generation of an active protein, which then acts on another zymogen substrates in a downstream part of the coagulation cascade. The most updated model of the coagulation cascade is shown in this figure. As can be clearly seen, blood coagulation develops through a series of coordinated enzymatic reactions that have the final scope to produce a sufficient amount of fibrin to stabilize the platelet plug at the site of the endothelial injury. In this ensuing slide, the same process is described in more details. Unlike the conventional representation of the coagulation cascade as a two-sided process, blood coagulation can only be initiated by factor 7, which is the first factor of the formally known extrinsic phase of blood coagulation. As you clearly see in this figure, factor 12, the first factor of the formerly known intrinsic phase of blood coagulation, does not appear anywhere. This is simply because factor 12 is not involved at all in physiological hemostasis, while it still retains its crucial role in laboratory hemostasis as the target factor for performing the activated partial thromboplastic time that I will simply call APTT from now on. Although I guess that some of you may be quite confused by watching this figure, I will do my best to try explaining in simple words a mechanism that is actually much more simple than what it seems. The original endothelial injury not only triggers platelet activation, adhesion, and aggregation, but is also associated with release into the bloodstream of prothrombotic substances, especially tissue factor, which is largely contained into endothelial cells. The tissue factor then associates rapidly with factor 7, so inducing the activation of the latter protein to activated factor 7. As I have earlier mentioned, this initial phase of activation has long been known as the extrinsic pathway of hemostasis, but should now be regarded as the tissue factor pathway. In the following stage of blood coagulation, activated factor 7 catalyzes the conversion of factor 10 into its activated counterpart, which in turn initiates the formerly known common pathway by promoting, in association with its cofactor activated factor 5, the conversion of prothrombin into thrombin. This last enzyme catalyzes the conversion of fibrinogen into fibrin monomers, which are then stabilized by the activity of factor 13, so that a stable fibrin network can be generated. Most importantly, the magnitude of fibrin generated through activation only of the former extrinsic pathway is largely inefficient to provide complete stabilization of the primary platelet plug, since it would be less than 5% of the total amount of fibrin needed to reach this target. Therefore, this mechanism would be substantially unable to stop ongoing hemorrhages. It is exactly at this point that an accessory but essential mechanism comes into play. This is formally represented by the intrinsic pathway of hemostasis, but now it is more appropriately defined in terms of thrombin burst. Specifically, the generation of thrombin through activation of the tissue factor pathway not only promotes the generation of fibrin, but is also effective to catalyze the activation of factor 11 to activated factor 11. On turn, activated factor 11 then catalyzes the activation of factor 9 to activated factor 9. Besides being a minor substrate of activated factor 7, factor 10 is then powerfully activated by activated factor 9 in association with its cofactor, which is factor 8. Thank you, Antonio. Under physiological conditions, the amount of thrombin and fibrin generated by the thrombin burst is thus sufficient to assure effective stabilization of the primary platelet plug and to arrest the bleeding. Already in this slide, you can see that there are two basic laboratory tests that are capable to globally mirror the function of activation phase and thrombin burst, that are respectively the prothrombin time, from now on referred to as PT, and the APTT. Fibrinogen is another ancillary test, which is specifically used for monitoring the targeted functional activity of fibrinogen. As previously mentioned, Although some pathology books still include factor 12 as an essential element for the activation of blood coagulation, the real contribution of this factor to the current in vivo model of blood coagulation seems mostly irrelevant, at least in the activation phase. Although it cannot be ruled out that the activation of factor 12 may occur after endothelial injury in vivo, considerable evidence, including that patients with homozygous deficiency for this factor do not experience significant bleeding, finally supports the concept that this protein may instead exert other important biological function, while its role in secondary hemostasis is probably less important. Definitive evidence about the probably insignificant role of factor 12 in the activation of blood coagulation come from many published studies, such as that shown in this slide, which specifically concludes that although it is commonly believed that factor 12 may be essential for surface activation of blood coagulation, individuals with severe deficiencies of this clotting factor do not experience clinically meaningful bleeding events. Yet, factor 12 plays an important role in laboratory hemostasis, since we have convincingly demonstrated that over 1/3 of a Pdt prolongation may be due to factor 12 deficiency. This is an important finding, since in urgent conditions when a complete panel of coagulation factors test is frequently unavailable, many surgeons may decide to postpone surgery or other invasive procedure just because they face a prolongation of their Pdt, which, being due to factor 12 deficiency, is completely meaningless. The patient history, along with clinical signs and symptoms, are crucial here, since none of these would be suggestive for the presence of a hemostatic disorder. As earlier mentioned, the hemostasis balance needs to be finally regulated to prevent excessive bleeding or undue thrombosis. Therefore, blood coagulation is finally regulated by several physiological inhibitors, which include the tissue factor pathway inhibitor, which was formerly known as extrinsic pathway inhibitor, antithrombin, and the protein C and protein S system. The most important of these is indeed antithrombin, since even deficiency in the heterozygous state may be associated with a disproportionate risk up to 20 times of venous thrombosis. Now, a brief description of the leading inherited platelet disorders. These are typically clustered into defects of platelet adhesion, defects in platelet aggregation, disorders of agonist receptor and signaling pathways, abnormalities of platelet granules, and disorders of platelet procoagulant activity. We will find a more precise description on this condition in the article shown in this slide. As regards the leading inherited blood coagulation disorder, they may actually involve each and any coagulation factor, but the most well-known, probably because they are also the most severe, are hemophilia A due to factor 8 deficiency and hemophilia B due to factor 9 deficiency. Globally, the severity of the blood coagulation deficiency can be classified according to the residual factor activity in plasma and their actual contribution to the hemostasis process. Therefore, severe hemophilia is defined when the activity of factor 8 and factor 9 is less than 1%, while the other factor deficiency becomes severe when the activity of the relative coagulation factors is between 5 to 10%. After this brief but hopefully clear description of physiological and pathological hemostasis, let's now move towards laboratory hemostasis and its integration with the patient history and clinics. Basically, an accurate diagnosis of bleeding disorders of secondary hemostasis should always encompass a multifaceted approach, entailing collection of personal and familial history, results of first-line or screening coagulation tests, which can then be followed by second or third-line analysis to definitively establish the specific nature and the severity of the bleeding phenotype. For reason of time, I will not go through this complex algorithm, which is however available to all of you in the set of slides uploaded in the FLM website. Just a few words to emphasize that the combination of first-line tests that are Pt, Aptt, and Fibrinogen, along with platelet function testing, will be a valuable guide for diagnosis of hemostasis disturbance, and even more importantly, the variable combination of their results is an efficient guide for ensuing further diagnostic investigation, more specifically aimed to clarify the specific nature of the underlying disorder. This slide summarizes the current armamentarium of laboratory tests available for troubleshooting a hemostasis disturbance. Briefly, the result of first-line tests should hence guide the laboratory or the clinician to performance of second-line tests, which provide a reasonable basis for a preliminary diagnosis. Third-line tests are then supportive for a final diagnosis and for identifying the type of factor deficiency. The inherent complexity of this approach is mirrored by the vast array of diagnostic techniques needed to carry out such an extensive panel. This would hence require performing clotting tests for Aptt, for Pt, for Fibrinogen, for mixing test, which is aimed to screen the presence of inhibitors of clotting factors, for the thrombin time, and for measuring clotting factor activity. Platelet function assays are instead needed both as first-line screening test, but also for studying platelet aggregation. Immunoturbidimetric assay would be needed for diagnosis von Willebrand disease. Immunoenzymatic assays would be needed for measuring the concentration rather than the activity of clotting factors and fibrinogen. Again, clotting or else chromogenic assays would be needed for measuring clotting factor activities. Finally, genetic testing is essential to identify the possible mutation underlying an inherited bleeding disorder. The investigation of thrombotic disorders makes no exception to this complex rule, since the active players are many and multifaceted, as you can see in this slide. Basically, venous thrombosis is a result of many factors that are clustered into genetic factors, acquired factors, and triggering factors. Then, laboratory testing is also essential for the diagnosis of venous thrombosis, which is typically divided into deep vein thrombosis, pulmonary embolisms, or both. Therefore, chromogenic assays would be needed for measuring antithrombin and protein C. Immunoturbidimetric assays would be needed for measuring free protein S. Clotting assay would still be needed for analyzing activated protein C resistance and lupus anticoagulant. Immunoenzymatic or immunoturbidimetric assays would be needed for measuring anticardiolipin antibodies and D-dimer. Finally, genetic tests would be needed for identifying factor V Leiden and the prothrombin gene mutation. At the end of the story, the hemostasis laboratory looks like a huge supermarket where multiple products are available for preparing an appetizing Christmas lunch. Obviously, not all these technologies may be used by all routine laboratories, since most of them may then transfer the samples to a reference laboratory in the local network. In turn, this reference laboratory should, however, need to implement a variety of analytical methodologies, so including clotting assays, chromogenic assays, immunoturbidimetric assays, immunoenzymatic assays, platelet functional assays, and finally, genetic testing. This general concept of laboratory networking strongly involves laboratory hemostasis for a variety of reasons. Basically, personalized medicine with strong impact on the future of the clinical laboratory, whose reorganization will be probably driven by many factors, such as healthcare reforms, cost containment strategies, consolidation of laboratories and in vitro diagnostic testing, as well as the impact of new technologies and tests on the existing laboratory organization. This would mean moving towards a hopefully brighter future for our profession, according to which hemostasis laboratory should be taken to a higher level of complexity, but without discounting the essential importance of quality throughout the total testing process. Since my time is ending, I invite those of you who may be interested in the ongoing organization of laboratory hemostasis to have a look at this recent article, in which many concepts have been more extensively debated. In the meanwhile, it is worthwhile reminding that the ongoing revolution of diagnostic testing, squeezed between reduced funding and increasing volumes, carries notable implications in the way laboratory resources are organized and coagulation tests delivered. It is also predictable that the newer generation of hemostasis analyzer may be designed to face these emerging needs, while they will maintain a high degree of testing quality. Therefore, moving towards the future will probably mean evolving from the current situation, which is characterized by many technologies and a number of different analytical platforms. As you can see in this slide, now we need an analyzer for clotting assays, chromogenic assays, and immunoturbidimetric assays, but we also need an analyzer for platelet function assays and immunoenzymatic assays. What is the future? The almost unavoidable scenario is the future, in which all these different technologies will be incorporated within the same analytical platform. Consolidation. Oops. Sorry, there is a slide missing. But anyway, we have figured it out what probably the next generation of hemostasis analyzer will be. And there was a figure that depicts the probably figure of a new analyzer. Well, okay, the slide is like in, don't worry. Maybe the design of the analyzer that we have dreamed is not so far from reality, and quite unexpectedly has now become the focus of many diagnostic companies. We are also conscious that the availability of multiple analytical techniques within the same analyzer, we also need a paradigm shift in the way laboratory hemostasis has been seen over the past decades. Since laboratory professionals would need to broaden their background, their skills, to embrace many different aspects that have laid in someone else's hands for ages. So the general aspect of a next generation analyzer for hemostasis testing include modular design and fitted for total laboratory automation, as well as many other features that will be described in this article that is contained in this slide. Unfortunately, my time is now over and I need to stop my presentation here. However, there are many slides that will be uploaded in the website of the EFLM will emphasize some of the concepts earlier discussed throughout this lecture. I sincerely hope that this presentation may be helpful for some of you who had the patience to listen to me. My kindest regards and my best wishes for a Merry Christmas and a Happy New Year to all of you, and I'm now ready for the question time. Thank you.
Okay, thank you very much, Professor Lippi, for your magnificent presentation. And I encourage you all to make your questions in the screen at the top of your computers, and feel free, please, to make your questions there. We can give you a couple of minutes.
think that was the slide.
Well, I can start, Giuseppe, with one question that arose for the very beginning, and it's I can read it. It says, when do you think that advanced genomic techniques like next generation sequencing can play a role in the study of a patient with hemostasis disorder? Does it make sense using this approach instead of direct gene analysis?
Yes, sure. As you know, there are many hemostasis disturbance and many hemorrhage disorders, for instance, like hemophilia A and hemophilia B, which have a quite different phenotype according to the genotype. So we are now performing gene sequencing for many patients with hemophilia A and hemophilia B just to identify the mutation, because the mutations are differently responsible to the therapy. For instance, there are some mutations that do not respond to some kind of factor VIII concentrates, but are most responsive to other kind of concentrate, for instance, containing factor von Willebrand factor, because the mutation involves the binding site between factor VIII and von Willebrand factor. Because one thing that I didn't tell in my lecture is that factor VIII also has also another foremost role in coagulation, that is indeed participating to the formerly known intrinsic pathway of blood coagulation, but it is also deeply involved in safeguarding the factor VIII within the bloodstream. It actually protects factor VIII from degradation. So if we can identify by NGS or other techniques that the mutation of the patient involves the binding site of factor VIII with von Willebrand factor, then we know that the therapy will be absolutely based on factor concentrates also containing von Willebrand factor. So my basic answer to your question is indeed this will be the future.
Okay, here we have another question. Thank you first. And how CFN, I cannot understand really the meaning. You imagine centrifuge. Yes, and
I basically understand the question, because in the slide, yeah, I have in this figure of what we think as a possible next generation hemostasis analyzer, we have also included the centrifuge inside of the analyzer. This was just for a matter of automation, because as you can see, the former generation of hemostasis analyzer were not fitted for automation. This would mean inserting the analyzer within the lines of clinical chemistry or hematology and whatsoever. So in our idea, having some sort of internal centrifugation for coagulation may be highly effective, especially because centrifugation of coagulation samples have different requisites than centrifugation for standard serum or lithium heparin samples. For instance, as for CLSI guidelines, hemostasis sample must be centrifuged for 15 minutes at 1.5 degrees, G, while we can centrifuge serum or lithium heparin sample at a higher speed for a lower time. So basically, having the centrifuge inside of the analyzer would speed and enhance the quality of this type of testing.
Okay, another question, taking advantage of your expertise in pre-analytics and hemostasis. This is really a question directed to you. Thank you, Dr. Lippi. How do you manage with samples with hemolysis, because it's a trouble for laboratories?
It's a big issue, not only for the hemostasis laboratories, but for whatever kind of hemostasis testing. We have just recently defined some EFLA guidelines for management of hemolyzed specimens. Our policy is that whenever hemolysis doesn't induce a bias that exceeds the reference change values of that specific test, the result can be released. After the bias is over, let's say, the reference values, then the result must be suppressed. That our policy is more or less conservative when the bias is, for instance, around 5 to 10%, but results must be suppressed when the bias is over the reference values. So just take it 5 to 10% as a general indication, but you have actually to go through the database of biological availability to check the reference change value of each test that you are performing. After, when the bias is over the reference change values, then results should be suppressed.
Perfect, thank you. Another question, what tests would you advise or recommend to use in the first line for platelet function, PFA or other?
Well, we are actually using PFA. I know that there are other tests like multiplate, and they are more or less the same. We are using multiplate PFA because we have a tender, and Siemens won the tender, so that's why we are using PFA. But I guess that whatever other type of platelet function test on microplates or on compact analyzer would work for the scope.
Perfect.
Obviously, platelet aggregation is not a first-line test. That must be actually our algorithm is based on PFA as a first-line test. Then, if the PFA is normal, we stop. If the PSA is abnormal, then we perform. Yes, I say. What is PFA? PFA is platelet function analyzer. Is a compact analyzer that has been developed by Siemens. So when results of this analyzer are outside the reference limits, then we start, let's say, second and third line testing.
Perfect. Another one, can adrenaline-induced aggregation specifically test aspirin administration? Yes. I understand.
Yes, yeah. We actually use PFA and platelet aggregation.
Perfect. Another question, please tell me what reference interval is it necessary to refer with the results?
I'm not sure I understand what this question means. What reference intervals is necessary to refer with the results?
Perhaps if I can guess if you can recommend any source of for reference intervals, general reference intervals for coag tests, or?
Sure. For hemostasis testing, they must be calculated because, as you know, there are still two anticoagulant mixture available worldwide, 0.105 and 0.132. So if you use one anticoagulant, it's not the same reference range as the other. We have also seen that also the brand of the tubes may induce some differences in calculation of reference intervals. So you have to calculate it on, as suggested by the FCC, on a population of at least 120 healthy, let's say ostensibly healthy person. We usually take blood from patient of the transfusional center, and we calculate our reference ranges of them.
Okay. Another question. Thank you, Professor Lippi, for your very interesting presentation, and some comment about the D-dimer role in the elderly with aging.
Yep. We know, obviously, that the dimer increases in parallel with aging, and the increase is, let's say, clinically significant after the age of 50. So we have now suggested to adjust the reference ranges for the aging of the patient, and basically every year of the patient we increase the cutoff in nanogram liter, the 500 cutoff by 10. So for instance, a 51 years old man would have not the 500 cutoff, but the 510 cutoff.
Perfect, thank you. Another question. Professor Lippi, APTT is not a standardized test. How can we choose Pdt reagent? That's the question.
Yeah. There are a huge number of reagents for the APTT. Kaolin, silica, ellagic acids, and many others. We are using, now in my laboratory, we are using silica, just for one reason, because silica is extremely sensitive to coagulation factor deficiencies. which means that all factor 12 deficiency will be stopped by the PTT because they will have an abnormal result of the PTT. But this is essential for us because PTT is also, silica as a reagent is also extremely sensitive to von Willebrand disease. And we had several cases of patients with von Willebrand disease that had a lot of bleeding problems after banal surgery, like for instance, tooth extraction and etc. So using silica would enable to recognize all the clotting factor deficiencies. Clinicians are not very happy about that, obviously, because we don't usually perform clotting factor activity during the night or during the weekends and etc. So whenever they have a problem with the patient, they have a prolonged PTT and they need to rely on clinical history, signs and symptoms. And I shouldn't say this, but you know that clinicians now are not so used to rely on clinics and patient history when they have a whole bunch of laboratory tests available for troubleshooting whatever kind of diseases.
Perfect, thank you. And what about the standardization? That's another question.
Well, there is no standardization for PTT. Because as I said before, you have to calculate your own reference ranges and you have to express a result in ratio, which means a ratio between the result of the patient and the result of the pool. The pool is usually composed on 20 different plasma samples collected from healthy people, and the ratio is 1. So a normal people should have 1, and our reference ranges is actually comprised between 0.80 something, 89, if I remember well, and 1.11. But there is no standardization. I mean, each laboratory has to calculate his reference ranges.
Perfect. Another question, what is your impression about the high demand of thrombophilia studies?
What do you mean by high demand? Sorry, I can't see the question.
Yeah, it's from Teresa Sanz.
What is your impression about high demand for thrombophilia studies? High demand means the high number of tests, probably.
Yeah, well, I guess.
Yeah, and the complexity. What we actually do is to start from the most frequent ones. And it also depends, obviously, on the clinics, because if you have thrombosis in a very young person, as I said before, you should first start troubleshooting the most severe inhibitor deficiencies. For instance, if you have thrombosis at 20 years of age, you start suspecting antithrombin deficiencies. While if you have, for instance, a 19 years old woman who has venous thrombosis with many other triggering factors, acquired triggering factors, for instance, immobilization, cancer, or whatsoever, we don't think at antithrombin. I mean, she would have thrombosis much earlier in his life. So we start from the less frequent, sorry, the less severe conditions like factor 5 Leiden or prothrombin gene mutation. So actually the decision on which test should be performed should be tailored on the patient. This is actually personalized laboratory medicine. So the clinical history should guide the decision on which test should be performed first.
Perfect. Another question, what are the most common reasons for low or large APTT results, and which cutoff would you recommend for rejecting or resampling?
Hi, Anna Maria. Nice to hear that you are here. Well, the most common reason for low PTT are basically two. The first one is a pre-analytical problem, because whenever you have a difficult venipuncture, then you have a massive release of prothrombotic substances, and especially you have massive contact with subendothelial matrix, which activates what I said before, the former intrinsic pathway of blood coagulation. As I said, in physiological hemostasis, factor 12 is not important, but is the target of the reagent that we are using for the PTT. So whenever the sample is has some kind of problem during collection, then we have short PTT. So it's not so unusual to have an PTT of 0.7 in a massive hemolyzed specimen or in a sample that has been collected with a difficult venipuncture. The second important reason is inflammation. All patients with inflammation have a lower PTT, and this is because von Willebrand factor and factor A are altogether are extremely responsible to interleukin-6. They are acute phase reactants. So whenever a patient has inflammation, the concentration of factor VIII and von Willebrand factor increase in parallel. So that's why patients with rheumatoid arthritis, for instance, tend to have low results of a PTT, and especially in sepsis. And this is probably sometimes misleading because we are expecting that in sepsis patient may have a prolonged PTT, but in infective sepsis, patient may start with a very low results of a PTT. As for the cutoff for rejecting or resampling, I would start from 0.8. Below 0.8, I would start to think that the sample is unsuitable.
Perfect. And another question: what about biological reference interval for test?
You can find them in the many databases that are available. I know that there is a project under the auspices of the FLM, which is now developing, and this project should actually merge all the available databases, because you know that the most accessed database in laboratory medicine is the so-called Westcard database. But that database was built by merging studies from different periods with different analyzer, different reagent, etc. So actually, the FLM is now working on this project, and all the studies will be selected, and hopefully this database will soon become available to all the FLM members, probably hopefully by the end of this year, or even sooner, maybe.
Right. The last
meanwhile,
question,
you can use the Westcard database.
Another one, how can we evaluate pathological hemostasis?
More or less is what I said before. There is a panel of tests, and this test must be decided according to the patient, must be customized according to the patient. So let's start with the most likely test in that patient and then move after.
Perfect. I don't know if there's any other questions. Okay.
Do you use the bleeding score? No, we don't use it. It is my personal impression, but I mean, I know that many centers are using the bleeding score, but our clinicians and also I am not really, how can I say, not really confident in using this score. There are many bleeding scores, obviously. There is not only one. There are at least 3. I'm not confident because the sensitivity and specificity of the test is far below 100%. So we are not talking about anemia. We are talking about, for instance, a severe bleeding disorder. And if we don't apply the correct treatment to the patient, then we can kill him. So I would only use a score that is 100% sensitive and specific. But this is my position, as I said before. So I'm not complaining if somebody else is using around the world.
Another question, it's about consecutive INR measurements which are not consistent.
In the same patient or in different patients?
I try to understand that in the same patients. Perhaps measuring with different methods or...
Well, it depends on the condition of the patient, because if the patient is on oral anticoagulant therapy, I'm referring to warfarin or other coumarin's derivatives. Obviously, they cannot be consistent because the therapy of the patient has changed from one blood collection to the other. If you are referring to two consecutive, very near ENR measurement, I would start to think that there is a first, a pre-analytical problem while collecting the specimen, or a possibility that should always be considered. Maybe the patient has been collected from another patient. So there is an identification error.
Another question is, do you have any comments about usefulness using fibrin monomers in pregnancy?
Yes, sure. Fibrin monomers have been used for a while during the past decades, but now they are no longer used because they have been completely replaced by D-dimers. So it's not a matter of pregnancy, it's just a matter of what kind of biomarker we should be using for diagnosis thrombosis. In this case, venous thrombosis. And the D-dimer has outstripped whatever kind of biomarker so far. So we are not using it, but I don't think that it's worthwhile using.
Another question was also related to fibrin monomers complex for diagnosis, but it has been answered yet.
Sorry?
I mean, there was another question related to fibrin monomers, but it's already answered with your with your answer.
Oh yes, yeah, sure. Yeah, I see that the question is more or less the same as before, because the Turgot says that he got an ENR of 8 after several measurements of 2. If these two measurements are for a reasonable gap of time one to the other, I would think that probably the anticoagulant therapy of the patient is too high, so he's taking too much warfarin. 8, it's a very risky condition. When we see 8 of ENR, we usually counteract the warfarin by administering vitamin K.
Another question is, besides deep venous thrombosis or pulmonary embolism, is there any other role for D-dimer?
Yes, sure. Intravascular disseminated coagulation. It's one. Actually, D-dimer is included in one. Is one of the tests included in the algorithm for the diagnosis of disseminated intravascular coagulation. Actually, in DIC, a negative D-dimer rules out intravascular disseminated coagulation with 99% sensitivity.
Perfect.
I see that Anna Maria writes that our neurologists like to use it for ADH cerebral thrombosis. Yeah, I mean, whatever kind. Now, we can discuss about the issue of venous thrombosis, because when we talk about venous thromboembolisms, we include all kind of peripheral thrombosis. So, yes, sure. For the diagnosis of cerebral thrombosis, D-dimer is quite effective. More or less like for diagnosis pulmonary embolism of lower limb thrombosis.
Another question is, what is better? And I believe it's anti-2A and
anti-2 or
anti-10A.
anti-10 testing. Yeah, in antithrombin activity, we are actually using anti-10A calibrated against heparin.
Right. And another one, prolongated APTT with first mixing test or different sensitivity APTT reagent?
Mixing test. I mean, prolonged PDT in explaining causes should be always troubleshoot by a mixing test. When I introduced the mixing test in my laboratory, there was some sort of reaction from the technician because they thought that it was really a different test to be performed, but actually it's very simple because you simply take one aliquot of patient sample, one aliquot of pool, you incubate it for 2 hours at 37 degrees, and then you remeasure the Pdt. If the Pdt corrects, then you have a factor deficiency. If the Pdt does not correct, there is some sort of inhibitor that can be a coagulation factor inhibitor, and I'm talking about acquired hemophilia, or an exogenous inhibitor like, for instance, heparin. But we perform a lot of mixing tests of a Pdt for troubleshooting an unexpected prolongation.
Another question is, in your lab, INR monitoring in patients with anticoagulant therapy normally done in hospitals or on desktop equipment, or they use POCT devices?
I would say 95% of the patients are still managed by hospital monitoring, and 5% of them use POCT devices. But this is mostly due to the fact that the POCT devices are not refunded by our national healthcare system. So they should pay for the device and for the strips. And the device costs around 800 euros, and each strip is around 10 to 20 euros. So it's not affordable to everybody. But maybe in other countries with different reimbursement policies, I mean, the POCT devices do not perform equally to laboratory testing, but their performance is still acceptable.
There's another typing question, I guess. No. Okay, I think it's time to finish. Well, there's another question. Can I ask a question about patient with DOAC therapy, direct anticoagulant therapy? Is it correct to enroll patient using this therapy which has antidote present, or is only correct use guidelines?
I'm not sure I can understand the question, but the use of direct oral anticoagulants, I mean, we should make a webinars especially devoted to the direct oral anticoagulants, because the discussion is so huge that it would take hours. But if I understand the question, it's correct to enroll patient using DOAC with antidote present. Now there is only one DOAC which has an antidote, which is the dabigatran. The other antidote is not still marketed in, at least in my country, but I guess in most European countries. So I don't really understand this question.
And the very last one, can you comment the influence of low platelets and hematocrit value on PFA analysis?
Yes, good question, very good point, because whenever there is a low platelet counts on a low hematocrit value, the PFA results is increased. So before making PFA analysis, you should also have a platelet count and hematocrit value tested before taking decision on result of PFA. Good question.
Perfect. Okay, so thank you very much for all the attendees. Thank you very much, Professor Lippi, for your splendid, magnificent presentation and the question and answer session. And I hope that this live webinar from EFLM has been valuable for you. Some of us have taken some message for our works, and thank you all for attending this webinar. And goodbye.
Thank you, Antonio. Thank you, Daniel. Bye to everybody.
Bye.